going to shift gear now and go very clinical about how I recommend you identify cardiovascular risk factors in people with psoriatic disease using current guidelines. These are my disclosures. All right, so we're going to attempt to do an audience poll. And so if you take your cell phone out and point it to the screen, you should be able to get the QR code off of there. Let's see, here we go. And now I'll take you to Slido, and I'll ask you your first question. And the question is going to be, which immune targeting treatment is proven to lower the risk of major cardiovascular events in randomized placebo-controlled trials? And your options are colchicine, JAK inhibitors, IL-17 inhibitors, methotrexate, or TNF inhibitors. So let's get our votes in. Rheumatologists are allowed to vote also, Artie? Yeah, okay. And people in the back able to vote? Is it working for you? I know we have 36 votes in so far. It's pretty good. No, it's okay. And I see, Andy, stop taking pictures of me, Andy. What are you doing? All right, I think we got Andy's vote in, and so let's see what the audience thinks. Okay, good. So I have an opportunity to do some teaching. So the right answer is colchicine. Okay, and colchicine works by blocking netosis, targeting neutrophils, and it's actually approved in the United States now for primary prevention of cardiovascular disease. And the reason why I want you to know this is that you have a lot of patients in clinic who will get worked up a cardiovascular risk. They find they're loaded with athero, and they're worried, what else should I be doing to lower their risk of cardiovascular disease? And colchicine is now another anti-inflammatory product that prevention cardiologists are now starting to use in the clinic as something proven to lower their risk of events. All right, so now we have a second opportunity. Now this is a answer all you wish. So you choose more than one answer. So again, bring your phone up and get the QR code here. And here the question is, when managing a patient with psoriasis, I do all the following, and you click all that apply. I educate them about the risk of cardiovascular disease related to psoriasis. I check their blood pressure. I order a cholesterol test. I screen for diabetes, like a hemoglobin A1C. I order an hsCRP to check for systemic inflammation. And I refer them to a preventative cardiologist if modifiable risk factors are present. How are we doing with votes? We got 21 votes, so it's to be speedy, folks, because the faster we are, the sooner we get to break. You know, got some snacks to have. Okay, we're at 36. Can I get to 42? Get to 42? 2 more votes, maybe. All right, I got to 40. That's pretty good. Okay, we'll close the poll in there. Let's see what we got. All right, so first of all, virtually all of you are educating. Okay, that's really important, and we've come a long way, right? Because before we started publishing a lot of this work, most people would say it's a skin disease, don't worry about it, you should be happy, it's just a skin problem. Now we know more than that. This is an audience that's very engaged in managing psoriatic disease. About 2/3 of you are screening for cholesterol, blood pressure, and diabetes. About half of you sound like you work with a prevention cardiologist, and the lowest one, hard for me to see, about hsCRP, but it's a small rate of that. Okay, so that's helpful baseline to see where we are. All right, so first of all, this is a humongous topic that I'm trying to cover today. There's over 4,200 citations on psoriasis and cardiovascular disease alone. And I just want to bring up a couple of key points as a clinical dermatologist you want to know about, is that the more body surface area someone has involved with psoriasis, the higher the risk of all-cause mortality is, the higher the risk of having diabetes is, developing it over time, independent of risk factors to these events. So as a clinician, when you look at a patient in clinic and you see their high body surface area, you now know this person's at risk above and beyond traditional risk factors you can measure. And then this is from Mona Stala's group that came out this past year, a smaller study, 767 patients in Sweden, but prospective study, and they basically showed that the PASI score was predictive of having MACE events, with every 1 point increase in PASI being associated with about 4% higher risk of cardiovascular events. More compelling evidence that just a simple visual examination of psoriasis has important prognostic information for the patient. Johan covered this, so I'm going to go past that. But this is a paper from Paul Ridker, and here they evaluated 30,000 patients in cardiovascular trials. And this is this concept of residual inflammation that Alvaro was getting at before. And what you're showing is people who are really clamped down on the cardiovascular risk factors. Their LDL is ideal, blood pressure is perfect, A1C is great, that people who have higher levels of CRP, hsCRP, have a higher rate of all-cause mortality and cardiovascular mortality. And so this is another reason why in clinical practice, when dealing with an inflammatory disease, you may want to think about ordering an hsCRP, because it gives you another piece of information, their body surface area, their joint disease activity, and something objective in the blood to help you think about what's going on with the patient, and a way to motivate that patient to say, okay, well, your skin is clear now, but you still have a lot of inflammation going on in your body. Maybe something else has to happen. Maybe you need to control your risk factors for heart disease. And this, of course, has been the big question going on for decades now. Should we treat psoriasis aggressively to lower the risk of heart disease? And a couple of provocative meta-analyses came out in the literature in the last year I want you to be aware of. A big one in rheumatology literature, psoriasis and psoriatic arthritis, 88 trials, 10,000 people. They basically found that there was no evidence that our therapies are lowering cardiovascular risk in these meta-analyses, and had an unusual finding that when you had a lower dose of IL-17 compared to a higher dose, that seemed to be associated with higher risk, that using lower doses of IL-17 compared to higher doses was less cardioprotective. And this paper came out in the GI literature, also sort of counterintuitive. This is now looking at 36 RCTs, 38,000 patients, and here they found all classes of drugs we use, IL-12/23s, JAK inhibitors, and anti-TNFs, all seem to be related to higher rates of cardiovascular events compared to those who were getting placebo during these trials. There wasn't enough statistical power to look at IL-23, but there the hazard ratio was elevated as well. So, some key points. Immune-targeted treatments may have paradoxical effects. We notice in the field of dermatology they can be very anti-inflammatory in the skin and then pro-inflammatory in the skin. The observational data we have available to date is kind of hard to interpret because people who go on biologics tend to be very healthy, much healthier than people who don't go on biologics. And they may be driving some of the benefits we see in observational data. And these new meta-analyses, I personally would not hang my hat on it. I think there's issues when you have large summaries of data, and more people drop out in the placebo group than drop out in the treatment group. And so there is really an imbalance in these meta-analyses. And so even though I think earlier a speaker showed that meta-analysis is the pinnacle of evidence-based medicine, not always. There's sources of bias that could occur in these studies that we need to be aware of. But the best we could say, based on our current knowledge, 2024, is that TNF inhibitors seem to be cardioprotective, but the data is somewhat inconclusive. And really the only drugs proven to lower cardiovascular risk that are anti-inflammatory in nature, based on event-driven trials, are canakinumab, an interleukin-1 beta inhibitor, and colchicine. All right, so what are the guidelines of care tell us to do? Well, basically we're asking you to do a cardiovascular risk assessment. Check their blood pressure, their cholesterol, screen for diabetes, educate them about the risk, and have these risk factors treated more aggressively and screened more aggressively when they have more severe disease. And this is sort of how this looks like from US guidelines. Blood pressure about once a year, A1C roughly every 3 years, cholesterol every 4 to 6 years, and then in age 40 to 75, the so-called golden window prevention for primary prevention for cardiovascular disease, they should have a more thorough cardiovascular risk assessment with risk calculation based on a formula that's available. So this is an example of a patient from my clinical practice. Middle-aged guy, long-standing psoriasis, moderate to severe disease and exam. He failed a Premolast. His blood pressure was fairly well controlled. He's obese. And I decided, I'm going to put you on a biologic. Why don't we get some blood tests on you, and let's screen you for diabetes and check your cholesterol. Hasn't been done in 4 or 5 years, I see, in your record. So he's pre-diabetic. His cholesterol is not terrible, but not ideal. And his 10-year risk, based on the risk calculation formula from the American College of Cardiology, is about 7%. And so the question is, what should be done with this guy? Well, the American College of Cardiology, American Heart Association, defines psoriasis as a cardiovascular risk enhancer, as well as multiple comorbidities our patients have. Like he has metabolic syndrome based on his BMI and his A1C, so that's another cardiovascular risk enhancer. He also has a family history, and he's got partially treated hypertension. So he's someone who really should go on a moderate intensity statin, okay? But our patients with psoriasis are often very resistant to go on medical therapy. They often don't even want to treat their psoriasis in many cases. And so in this case, if the patient's uncertain about it, you could do further risk refinement through cardiovascular imaging, what's called a coronary artery calcium score. And I wonder, this is widely available in the US and Europe. People have coronary artery calcium scores where you are? Some hands up for that, yeah? All right, so basically, this is from the guidelines in the US. Dan Sofer is a preventive cardiologist I work with, and the patient got a score done. He's in the 75th percentile. That's his LAD that's lighting up there. He's now convinced that as the proof in the pudding, that he has coronary disease, and he's now on a statin, which is part of what guidelines of care looks like. And so one of the key points I want to make in this lecture is that just how we've taught you for years that you should work with a rheumatologist to manage a patient with inflammatory arthritis, you want to have someone in your community who's tuned in to prevention cardiology, so you can refer patients to when trying to work with folks. And I recently published this paper with Dan Sofer in Clinics in Dermatology. It's very much a how-to use guidelines of care to assess risk in cardiovascular disease for psoriasis and then manage it in a multidisciplinary way. The problem is that we really do a terrible job of this, at least in the United States. So in a paper that a student of mine published recently in JID, we studied US data from the CDC and found if you're 40 or older seeing a dermatologist for a primary encounter of psoriasis, less than 3% of the time is your cholesterol checked, less than 7% of the time is your blood pressure checked. Kind of abysmal. And another major paper came out about a week or two ago. This is not a dermatology paper. They looked at about 250,000 people with diabetes in the US to see are they on statins like they're supposed to be. And if you had psoriasis and diabetes, you were less likely to be on statins. Okay? So they have higher risk from psoriasis, less likely to have it adequately managed per guidelines. So we're trying to tackle this problem with the Prevention of Cardiovascular Disease and Psoriasis and Psoriatic Arthritis study. It's called a CP3 study. And essentially, we're building and testing a centralized care coordination model to try and help patients get better screening of risk factors and better management of risk factors through care coordination. And we learned from the initial work that was funded by the National Psoriasis Foundation is that when we survey dermatologists and rheumatologists, we realized they're very comfortable ordering these tests, but not comfortable interpreting them or managing these tests. And that's where care coordination comes in. The other thing we learned is our patients actually value what we as dermatologists have to say about cardiovascular risk. When you say, you see that rash on your skin, that puts you at high risk of heart disease, they take that very seriously and follow up on our recommendations. And so what a care coordinator is someone who's an ancillary health professional. Their job is to coordinate the care between two or more specialists in medicine. And this is a standard practice in the US system. It's been shown if you have diabetes and depression, a care coordinator gets better outcomes for both their A1C and their mood. And a study in Canada has shown people with inflammatory disease, they will lower their predicted risk of heart disease by about 25% by using by using the pharmacist as the care coordinator model. So this is a very easy approach. We call it as easy as 1, 2, 3. Basically, the dermatologist educates the patient and orders the appropriate tests based on the guidelines of care. They document a medical record, and if things are abnormal, they say, okay, your risk factors are abnormal, you need to see the care coordinator. And a pilot study we presented in Tokyo at the ISID meeting and recently published in the GID, what we found is that overwhelmingly people got their labs done. So more than 90% of people got their lipids checked, their A1C checked, which is a really high bar of adherence if you think about it. Overwhelmingly, the patients found this was acceptable and feasible. About a third of people had newly identified elevated cardiovascular risk that they weren't aware of before entering this analysis. And this is in a group of populations that already does a lot of screening of cardiovascular risk factors. So even my own patient population, we're missing patients. And now we're launching a more definitive study, a 500-patient study across the US to more definitively test this hypothesis. So what do patients say? Well, I never heard about the relation between heart disease and psoriasis, so I was a little surprised to hear about it, but relieved that there's support and this focus in order to help us manage this. So, it's pretty overwhelming for a patient to be in your clinical practice and us to say, well, your psoriasis is clear, but now you have to worry about this other issue, and then poof, we're gone. So care coordination is that extra time the patient gets to meet virtually with the care coordinator to get the education and handholding they need to intervene on cardiovascular risk. All right, so now we'll hear from one of my patients.
His psoriasis is now under control, and because people with the condition have an increased risk for heart disease, Kim was referred to a cardiologist who found he also had coronary artery disease.
At first my reaction was, wow, that seems like a stretch, but the more I thought about it, it makes sense. if there's inflammation all over the body, that there may be inflammation inside as well.
Kim's dermatologist, Dr. Joel Gelfand, says there are a variety of effective treatments for psoriasis.
Okay, so that's a teaser for my next talk, if I get invited back. But I think Kim said it so well, right? And I remember that conversation was very definitive. It was actually telemedicine at the time. We went over things with his treatment options. We're going to get your skin clear, but we need to worry about these issues also. And it's exactly what I said. Like, you have this rash all over your body. That's a sign of inflammation inside your body. We need to check these things out. And you can see how for a patient that's much more concrete than saying your cholesterol is elevated, you got to treat it. Because you feel fine when your cholesterol is elevated, right? Patients don't make that connection. We have this advantage as dermatologists in a visual specialty. CP3 is designed to be a very pragmatic clinical trial. I invite you to come to Late-Breaking Clinical Trials Research on Saturday. I'm going to present the LIGHT study, a very pragmatic study embedded in routine care. But the idea is that this criteria are very simple to enroll. They are 40 to 75. That's a key window for prevention. They're being seen by a dermatologist for routine encounter for psoriasis. And they're excluded if they're already on lipid-lowering prescription medications or they have known cardiovascular disease. And the primary endpoint is going to be, can we lower their LDL cholesterol 6 months after them getting the education and getting screened and educated by the care coordinator? It's really a surrogate for, and these people who have higher risk of cardiovascular disease, who we know from large-scale trials should go on a statin to lower the risk of morbidity and mortality. Can we get this patient population who's often resistant to treatment to go on the appropriate medical care and dietary and lifestyle changes to improve their risk of heart disease? So I'll just end there by reminding you, this is a systemic disease and obviously requires comprehensive care. It's part of the thrust behind the symposium today. And if you're a dermatologist in the U.S. interested in being involved in this research, by all means, be in touch with us. We'd love to have you involved as a study site. And if you're international and want to learn more about what we're doing, we're happy to share materials with you so you can do this work in your own standard practices back in your home countries.